Hamilton, Ontario.
Hi, everybody. I'm Ann Pagano. I'm a licensed clinical social worker in New York and also work as a geriatric care manager.
Hi, I'm Linda Fay from LifePod here in Edinburgh, and I am hoarding specialist.
So good morning, everyone. Welcome to the session. We're very excited to be here with you. Our goal for today, I've just got a couple of slides, but really this is case discussion. And what we wanted to do is to bring together the four of us who do slightly different things, lots of overlapping things, but slightly different things in our work with people with hoarding difficulties. And we wanted to present a case to you and then step by step work through some discussion about our thoughts and our approach from multiple perspectives about how we would best support this individual. So I'm going to share my screen in a moment and get the case set up. We are very open if people have questions or comments or their perspectives that they would like to share along the way. So please don't hesitate to do that. We'll monitor the chat as we go along to see if there are other comments and questions along the way. And so let me share my screen to get us going. Okay. So just to get started, so this is our case discussion, and we did introduce ourselves. And like I said, we all come from slightly different backgrounds with overlapping interests and overlapping work that we do, but we're going to try to bring some different perspectives to the case. Our case is an amalgamation of many people that we have seen with hoarding difficulties. So it's not an actual person that any of us have seen, but rather kind of pulling together a case that we thought was sort of helpful and instructive. So Janice is the client we're going to be talking about today, and we're going to reveal and unveil some characteristics and details about Janice's situation, and then we're going to pause and have discussion at various stages, and then reveal a little bit more about what we theoretically would have learned about Janice. So just to get you started, Janice is a 66-year-old woman. She's divorced and lives on her own in a mid-sized US city. Janice has 3 adult children, and she raised her children as a struggling working single parent. 2 of them live near Janice, while the 3rd lives in a different part of the country. And they all have quite good relationships with Janice, so regular contact, very much by phone at this point. Janice retired 3 years ago after working for over 30 years as an administrative assistant at a public school. Since her retirement, she's been experiencing some difficulties. She has a chronic knee and hip problem, which has really restricted her mobility. And as a result, she's gained about 40 pounds and is noticing some trouble with mobility. In early 2019, she had a fall inside her house, and that resulted in a broken hip. So she went into the hospital for hip replacement surgery. And after that, during her discharge planning, staff from the hospital went to Janice's home to ensure that the home was ready to receive her again and could accommodate her using a walker, which she would need to do for a little while. And they found the home in a state of disarray. Boxes were precariously stacked in the entrance of the house. There were piles of unopened mail littered on the floor. The fridge was full of food. Lots of that was spoiled. They noticed dirty dishes piled in the sink. They saw quite clear evidence of mouse droppings in the lower cupboard, suggesting a potential infestation. The sofa in her living room was covered with clothes and unfolded laundry and books. Her children were contacted by the hospital discharge planner to intervene. And in the interim, the hospital discharge plan was shifted so that Janet would actually go to an inpatient rehab to buy some time so that her home could get more functional for her return and be safe for her. None of the children had actually visited Janice inside her house for over 3 years. All 3 of them reported that they remember their mom was a bit of a pack rat and had a lot of attachment to things, maybe kept some sentimental items when they were young, but they were now concerned that the amount of items around her home had substantially grown. Janice reluctantly agreed to go to rehab, but became quite agitated with the thought that her children might go into her house and make decisions about her possessions. So the children reached out to a local family service agency for some advice and assistance. So with that said, that brings us to our first set of a couple of different discussion questions. And so we're going to turn to Anne in a moment to kind of lead our discussion, but certainly all panelists are welcome to contribute, and all audience members are welcome to contribute. But our first set of discussion questions really are around things to do with, is this probably hoarding disorder, or are these behaviors linked to another clinical or cognitive issue that Janice might be experiencing? What kinds of comorbidities should we be thinking about at this stage? Who should be involved? Who should be involved in terms of the service provisions? And then we also want to talk about, if there needs to be service providers involved, who should they be? Sort of thinking through a multi-agency collaboration, thinking through the different assessments, thinking through the very practical questions around funding. So who's going to pay for the interventions that might be needed, and thinking about that initial action plan. So with that said, I'm just going to stop my share for a moment, and maybe I'll ask Anne to sort of start out with a few comments, and then the rest of the panelists to jump in.
Great. Thank you so much, Karen. So as a licensed clinical social worker with a lot of history in medical social work and care management, I'm going to, for the purpose of this case, wear my care management hat so that I more likely would have been on the end of the referral source in the community versus the poor discharge planner who's sort of been caught with this situation. I also want, if any of you familiar with hospital discharge planning, to note that Janice was very lucky to be in a hospital that still sent out staff to do in-home evaluations. We know for cost perspectives that is not the norm anymore, so that the discharge planner may not have even had that heads up in knowing what was going on in the community. So we know that we had a heads up. But I do want to refer back to those of you who have been participating in this conference, as of yesterday. Many of you may have heard Dr. Gail Steckity reference an assessment tool called the Clutter Image Rating Scale, which can potentially be used as a very effective discharge planning screen. I use the word potential because we've now learned that people who live in overly cluttered homes may not fully disclose the information out of fear of criticism or exposure. But sometimes a neighbor or a family member may also be able to weigh in and provide their perspective. The key takeaway is that if the questions aren't asked, the information may not be provided. So also please note that we set this case in 2019 pre-COVID time, just to be able to put in a full consideration of services, barring whatever restrictions are going on in your part of the country or the world. And we know that everything is fluid at this point. So the first consideration is this hoarding disorder versus hoarding behavior? And having clinical training in both hoarding disorder and other mental health issues, the first thing I would want to do is what I refer to as forensic exploration into the noted timelines of the hoarding situations to see what the roots of this hoarding behavior might be. And too many people refer to cluttered spaces, or what I like to refer to as high content homes, as hoarding, without consideration of the other factors. So I work with the predominantly older population of clients who may have been functional and able to maintain the upkeep of their homes and take care of themselves and their personal activities of daily living, up until chronic conditions slow them down and make daily chores a lot more difficult. This is when we often see the start of dysfunctional living spaces start to evolve, with reduced cleaning, difficulty shopping and cooking, and reduced personal hygiene or medical oversight. These are situations frequently referred to as self-neglect. They are not overly attached to the items or the clutter around them and are not adverse to discarding. They just can't cope. Losses in life, creating depressive moods, can also enhance the potential for self-neglect, as well as cognitive issues such as short-term memory loss or dementia. We know that Janice's home was in disarray, and the fact that she fell and broke her hip may lead us to assume it was due to limited ability to ambulate around the boxes and piles of belongings. The unfolded laundry, the stacks of mail, and spoiled food in the refrigerator all indicate that she was not coping with her daily activities of living and that self-neglect was evident. However, with further information exploration, her children had also referred to her historically as a pack rat. And to embellish this case study just a bit, I'm going to say that the children, when they did go to visit her home and viewed her current home situation, were able to recognize historical collections of items such as stacks of years of newspapers and an excessive amount of their old childhood possessions still evident in the home, indicating that hoarding behavior prior to her retirement and subsequent fall and hospitalization. A hoarded environment is a hoarded environment, no matter what the roots, and it does need to be addressed for remediation, no matter what the actual cause is. But what we now know from hoarding disorder research is that the approaches should be matched to what the identified client is coping with. Someone with self-neglect may welcome supportive cleaning and organization with relief, while someone with hoarding behavior or hoarding disorder may become anxious and resistant. It's my opinion with Janice that we are dealing with self-neglect layered on top of hoarding behavior. So then I want to jump to other potential comorbidities. We now know, based on the overview with Dr. Frost and Dr. Steckity yesterday, based on the DSM-5 criteria, we would want to initially screen to make sure the hoarding symptoms are not due to a medical condition like a traumatic brain injury or a cerebral vascular disease. And we also want to make sure that the hoarding symptoms are not restricted to the symptoms of another mental health condition like a higher factor of OCD, decreased energy and major depressive disorder, delusions and schizophrenia or other psychotic disorders, or the cognitive deficits and dementia. So Janice has depression. She does also have a traumatic history. She had a divorce, and for whatever reason for the divorce, it left her a struggling single parent. She did go through a retirement, and as an empty nester, Janice most likely had the most social contact with her colleagues at work, and it provided a daily routine and financial income for her. If she enjoyed her work, she could have also lost the satisfaction of her professional work identity, leading to an increased sense of depression and loneliness. And now she's in the hospital after a traumatic fall, after traumatic surgery, and now being faced with the anxiety of the unknown of going to an inpatient rehab and knowing that her home environment has been exposed to others, both her family and outsiders. So who should be involved? The key word is should, but from everything we know, in your minds as I'm talking, who out there knows who must be involved? And that would be Janice. We always want to make sure that the person who we are working on behalf of and for is the leader of the team, is the one guiding the decisions. We want to be able to inform and support and help reason. But ultimately, Janice is fully cognitively functional. So she is an independent, autonomous, competent person who we know, again, from other conference presentations yesterday, is fully competent to be able to reject any kind of interventions that we may feel would be important for her to accept. Now, we would want to make sure that Janice understood the pros and cons of her decisions and what the potential consequences and outcomes might be. We want to collaborate with her and work on her primary goal of returning to her home environment. But how would we do that? And for Janice to understand what might happen if she rejected any kind of help. And the key thing that comes to mind is that when she completes her rehabilitation in the short-term rehabilitation program, they may say to her, we cannot complete a comprehensive discharge plan with you because you do not have a safe home to go to. And if Janice rejects other options, which might be staying there on a long-term basis, which Janice is certainly young and doesn't need to suddenly go into long-term care, she would really need to understand what she needs to do, or that she would be forced to sign out against medical advice, which would then indicate a referral to adult protective services, which would just drag her down into the mire of organizational angst in terms of people peering into her private life and her private environment. So getting to the should point of who should be involved, family, I believe first and foremost should be involved as supportive and loving children. They've already identified that they're in touch with her regularly and have a good relationship with her. We don't know the details of the family dynamics, but the case does state that they have a good, strong relationship. Many times, family members really try to be the forefront on the people who try to remediate the situation, and that can cause friction within family relationships. So first and foremost, we always want to support the family dynamics first and offer to the family and to Janice that the family doesn't necessarily have to be part of the actual remediation process, but to be there focused, to be of her support. We want to consider her primary care physician, her maybe a psychiatrist and a therapist. She's dealing with a medical issue with her hip. She's obviously depressed and now very anxious based on everything that's been happening and the exposure of her home. We also, I'm going backwards. We also would really encourage the intervention initially of a professional organizer who can go in with professional eyes, assess the situation, and probably be the first person to work with Janice to recommend and identify a harm reduction team of professionals who can get her home good enough for her to be able to return home safely so that she can continue with visiting nurse services for continued physical therapy and readjustment to her home environment, maybe using a walker that she didn't use prior. The likelihood is that with some creepy crawlies present, that an exterminator would be indicated. Possibly the professional organizer might see the need for a deep cleaning remediator. From Janice's perspective, she may be able to identify a trusted ally, maybe a neighbor or a friend, and also the potential of a coaching support, much like the mutual support services that we've heard from Lee Shore yesterday. So at this point, I'm going to turn the conversation over to Linda Fay.
Well, may I step in very quickly, panel, because we have an excellent question, and I thought it was the right time to perhaps address the question and then turn it over to Linda. And so somebody has asked, if the hoarding is a byproduct of another comorbidity, should we be calling that hoarding behavior, hoarding tendencies, obviously not hoarding disorder because it's not meeting those DSM criteria. But the comment was a really good one, which is that, hoarding behaviors and tendencies and hoarding disorder, that starts to get confusing. And should we be actually using different language? So I'm going to open that up to the panel and get perspectives on that.
Yeah, I think that's an excellent question. I know sort of traditionally, or what the common practice is to call it hoarding behavior, but probably it's more accurate just to call it clutter. because hoarding, the essence of hoarding disorder is this excessive attachment to possessions. And really that's more the key for what we think of when we think of hoarding. Now, there are lots of other pieces of the diagnostic criteria, but it's the attachment to possessions that really characterizes hoarding. And with these other, as a secondary symptom of OCD or of depression, we don't see that layer, that kind of attachment, that it's really a function of this other symptom. The clutter builds up as a function of the other symptoms. So I think it's a great question, one that hasn't really been addressed in literature as of yet.
Yeah.
We also know that the term hoarding, we've already moved from describing somebody based on their behavior as a hoarder. We know that that's no longer an appropriate way to define somebody. But even the word hoarding, with the context of what the word means in terms of social media or some of the television shows, it's often helpful not to have that word in any of the discussions with the key person, because who knows how people interpret the word or the connotations. And we want to be really careful not to label somebody.
Yeah, excellent questions. Thank you so much. There's 2 more questions in the chat, but I do believe I'm going to hold on to them because I'll let Linda share her piece. The questions have to do with the financial implications and how to get funding. What if the family can't afford some of these services? Those are excellent questions, very practical, important questions for those of us in the area. But I think Linda was going to touch on some of those, so we'll see what's left at the end if you guys still have questions. So I'll turn it to you, Linda, for the next discussion.
Thank you. So yes, I'm just going to talk about the clutter. So thanks for that, Randy, because actually it doesn't really matter. The reasons in many ways doesn't matter at this stage. What matters is getting the person home to live in a safe environment. So what I would want to do at this stage is, as Anne was saying, is look at all the people that should be involved in coming up with a plan of action so that we can get Janice back home. There's only one other type of professional that I might add into the list that Anne ran through there, and that is a housing provider, because sometimes depending on who the housing provider is will determine some of the activities that take place. So first thing, I think we need to do a full and comprehensive assessment of the situation. I would want to have, right at the offset, I would want to have a conversation with Janice, get her view on things, what was happening with her, just previous to her visit into hospital, how she's feeling about things, and is she willing to accept help from professional organisers, hoarding specialists to go in and help her. Personally, what I would want to do is reassure her that we, are not going to make any decisions without discussing everything with her. She's the ultimate decision maker, but of course we need to make everything safe for her to go home, and that would she be willing for us to do some work in the home while she's not there, while she's in hospital recovering. And of course that's when we would have to bring in conversations like the funding. So as we know, it can often be quite an expensive project, and we need to work out where the finances are going to come from. So part of the assessment, it would be talking with Janice, talking to the other professionals, get an idea of how long do we have. For example, if Janice is going to go into respite care, is that going to be for 2 weeks, 2 months? That will give us an idea of how long we have to work with. And the other things that we may need to consider when she comes home, like will she need ongoing help at home once she's back, or when she's fully recovered? Will that be her, or should she have full mobility and be able to manage at home on her own, or is there an expectation that people would have to go in regularly? And I'm just trying to think of all the others. So immediate risks, of course, what we'd have to assess is fire safety, environmental health, all of those things that would need to be dealt with more immediately, and because they're the things that obviously would have to discuss with Janice in terms of making her home safe and relatively comfortable for her to return home to. And you know, if we are looking at bringing in other agencies, we need to get her permission to do that, and then again comes into the funding question. So it always comes back to funding, unfortunately, but that's just the way of the world. And then, you know, we'd agree with Janice what we'd prioritise to do to allow her to come home, and then what we could work on with her longer term to hopefully reduce and then manage the clutter in her home. So what we would want to avoid doing, if at all possible, is clearing out her home, because that's usually not necessary, and we don't want to add to the trauma that she's already experienced. So we would do what's necessary, what needs to be done in the immediate future, and then look at a longer term plan with her.
Thank you, Linda. I have a question in the chat that I'm going to bring up now as well. And I think it is a question that I've struggled with myself. So I'm curious about how the panel would like to answer this, which is, you know, how basically it's the idea of competency. How can someone be competent but still be living in such a state of disarray that, you know, the outside observer can see is so risky? Are ways of assessing competency actually getting at the idea of competency adequately enough? The question writes, if a person can answer some basic questions, they're considered to be able to make sound decisions. And I would agree with that. I think we often find that people are competent, even though they are making decisions that we think are unhelpful for them. So I'd like to open that up. It's a bit of a deviation, but I think a really good question and a time to answer that. So to see if the panelists want to comment on that one.
Yeah, I think one of the issues with competency is that most competency exams are done in an office and not in the person's home, and so that sort of colors it, because they don't really see that the evaluator doesn't really see the dysfunction, and so a description of it doesn't often carry enough weight to make it clear that the person is neglecting things that may put their lives in danger.
I'd also like to add that with a lot of the cognitive assessments for competency, insight is usually not part of those evaluations. So when we find that somebody really has good grasp and competent in many areas, the insight piece of it may be what's severely challenged. And in working with, in New York, what we call guardianship cases, there have been certain situations when people who have just flat out rejected their to address their environments and are at severe high risk of being evicted or homeless. Sometimes guardianship judges have set out limited guardianship capacity to allow oversight to work with that person and override their limited insight to start to engage some services to be able to get them back into the home. And then with it being a limited guardianship, it would be pulled back because the person is technically competent in other areas.
If I may, so I think, and what you were just referring to there was perhaps the extreme end of the scale, where, you know, if you're at a point we're talking about guardianship or eviction for someone, it's it's already at a critical point. But if we kind of just pulled back a few steps from that, where a lot of people are in a space where the situation is bad, absolutely, but still manageable with some support and intervention. But what sometimes comes into play when people are carrying out assessments is personal standards and judgments, and that can make things really difficult. And just as an example, one I often use, because it's real and happens quite often, is if I'm working with social care or housing professionals, they may want a person to have a bed in their home to sleep in, because in their opinion people should sleep in a bed, but actually not everybody does want to sleep in a bed, and so that comes down to personal choice. And so, if you're going through an assessment and it's a kind of a tick box exercise of, does this person have somewhere to sit, do they have somewhere to sleep, or a bed or whatever, then it's, I think, just being careful that when you're carrying out these types of competencies and assessments, that your own standards and judgments don't creep into that.
And I might add, it is often very difficult to determine whether someone has insight because of a whole host of other factors: defensiveness, fear of some kind of event, sort of a traumatic event by like someone coming in and taking all their things away and so forth. So there are a lot of reasons why people will deny that they have a problem and they have symptoms. Yeah. And it's not always the case that they don't recognize it. I think a good marker of recognition is more whether or not the person recognizes that they live differently than other people and they try to hide it. And I think then you get to see there is some insight there, that there's something different, there's something going on. Mm-hmm. But outside of that, it's really hard to determine whether someone really has insight or not, especially from an observer perspective, because we look at a home that's full and we think, how can this person live this way? And so we get this notion that maybe they don't recognize it. And then we try to convince them. And of course, that often backfires because we're trying to argue with them this point of view that's different, that somehow there's something wrong. And so they feel the need to argue back, and then it gets into a tug of war.
Yeah. And that's really useful, Randy, just to, if someone does acknowledge that, yes, they think they're living slightly differently to most people, and they are hiding it, and that's great, because then that gives you an opener to a conversation of, well, what's driving the fear? What are you worried about? And it will be usually because, I know that if I let somebody in, then they're going to come and take all my stuff away, and just that, getting that little chink then opens the doors to a conversation that you can have.
It's such a perfect segue. Thank you all for us to move into the next phase of our case, because we want to just present another piece of what we've learned about Janice. So bear with me. I'm just going to share my screen briefly to then talk about more information. So as part of the action plan, we do get some service providers involved. They start to meet with Janice. She reluctantly attends the meetings. She downplays her difficulties, very consistent with some of the comments we've been hearing. She says the problem really isn't that bad. Other people are overreacting. At the end of one meeting with a clinical social worker, she says, "Thank you for your time," but she declines to meet with them again. And the following day, one of Janice's children reach out to the social worker in a panic. So the children now are aware of what's going on in the state of the home. They're very concerned and worried about Janice. They're imploring the social worker to not give up. And they're very certain that she's going to, or very worried that she's going to have another fall and hurt herself again. So the next set of discussion questions we thought we would go into is very much about the idea of how on earth to motivate and engage someone who's competent, seems to be quite competent and not really that interested in engaging the services. And to me, this is the $1 million question. So I'm not going to answer it perfectly, but I'm certainly going to give you some observations and thoughts of the work that I've done, because my work sort of starts at this point and then moves into providing cognitive behavioral therapy, which we will talk about in a little bit. But that idea of how do you engage someone who maybe isn't all that interested in showing up to receive some sort of an intervention or get involved with all these active supports that are being put in place on their behalf. And the very first thing I think is important is something that our panelists have already talked about, which is the huge importance of involving the person and providing really clear, transparent psychoeducation about what's going on, who's involved, why we're doing what we're doing. And then in my opinion, a huge part of that is to really speak a lot about the harm reduction model. I do think that people hold lots of misgivings and assumptions, and perhaps based on previous experiences they've had where somebody has come in and done a large scale clean out on them without their permission, or people have come in and tried to be helpful but have done things in a way that felt very intrusive and not consistent with how the individual would have wanted to do that. And so really sharing the harm reduction approach and what the kind of the goals are. I always say it's about safety and it's about comfort. And what that means is we just want you to have a safe environment where there are no risks of things like falling again, tripping down, your stairs, which might be cluttered, having a fire, all of these things that we worry about. So it's basic safety and then basic comfort. And I agree completely with Linda. I don't mind if people want to sleep in a recliner, if that's where they'd like to sleep, but I want them to have a comfortable place to sleep and a comfortable place to sit. And so what that means, I think, is that we can share with people that the goals are not to clear things out. The goals are not to get rid of a lot of stuff. The goals are to make the living environment safe and comfortable for the person in a way that is comfortable for them. It doesn't have to be my version of comfort. It doesn't have to be someone else's version of comfort. So to me, that's been massively influential in the work that I do, just really setting the bar for people and being really, really clear about our goals and how it probably looks very different than what they're expecting or assuming. I think we need to be very clear about what will occur and what won't occur. Sometimes we are talking about situations where there is a fire risk, the fire department has been involved, and there are expectations. So that has to be clear about what an external agency like the fire department has set out. So we do need to share that. But in Janice's case, it's not the fire department. It's really about sharing the idea of trying to get her home comfortable so that discharge planning can proceed and everybody can feel that she's going back into a safe environment. The next step, I think, in terms of talking about motivation and engagement is investigating or exploring with the person some of their personal barriers to change. So thinking about the things that they're identifying that are going to be hard about this. And sometimes the barrier to change is clutter blindness or a lack of full insight or not really appreciating the gravity of the problem that that exists from other people's point of view. And that has been something that has plagued me. And I've thought a lot about how do you help people move through clutter blindness? I don't have any miraculous suggestion, but I do have a client who once told me that when she went away on a 2-week trip to visit someone and then came back, she saw her home and the degree of clutter through a completely different perspective. And then I had another client who said, I took pictures to share with my therapist. She was already engaged in therapy, but I took pictures to kind of, share progress. And she said, looking at the pictures that I then sent somebody else gave me a little more appreciation for what this must look like to someone else and some of the concerns that people were sharing. So these are not, fail-safe things, but these are little ways of potentially encouraging a little bit more awareness or appreciation of what the difficulty might be. But we also have to think with Janice, a huge barrier for her is going to be the physical limitations that she has. So prior to falling and having her hip replacement, she already had physical limitations. She was having trouble ambulating. We don't know if her fall was because of clutter or was because of her physical limitations. And so I think really appreciating and thinking about some of the physical challenges she might have about trying to make some changes. And so that's where I think talking to her about how she would think, what would be a reasonable way for her to kind of work around that barrier. And sometimes, having a trusted person, like one of her kids, who is the person who helps her move things or put things in a safe place, to create some pathways to clear the stairs, things like that. Some of my clients have said, if she was a little more physically capable but wasn't comfortable having someone in to do the help, moving big items on furniture sliders, to be able to move things so that there's a clear pathway. There are creative ways that we can work around barriers. But it's really important, I think, to respect and have that discussion about what the person thinks the barriers are. A lot of time the barriers are also emotional. This is hard. It's difficult. As Randy said, the core problem here is this excessive emotional attachment, to possessions. That leaves people in a really vulnerable position, and we have to be respectful of that. I guess that the next thing that I would say in terms of this idea of motivation is really engaging with the person on their particular reason for change. And this is where I think we need to be very broad and creative in talking with people about what's their hook. So everybody has a hook. We can hook people in something. And for some people, the hook is, I do, want to have my kids and my grandkids over. For some people, the hook really is, it's personal. I do deserve an environment that, that feels safe to me. But for other people, that's not the hook. And we can bang away on that and wish that they wanted this for themselves and keep pressing on that issue, but that's not the hook. The hook for some people is, I want people to stop talking to me about this, or I want somebody to stop knocking at my door, or I want somebody, to stop calling me about this issue. I want outreach to stop coming. And that's fine. I think that's a completely fair and reasonable hook. And so I think our job is to find out for each individual, by having a chance to listen and hear their story and hear their concerns, and then hear what do they want out of this situation. And if the very minimal thing we can get is that I want people to stop asking me questions about this problem, great, we have a hook. I can work with that. So I think that that's a really important piece. And if you're interested, Randy and Gail have a whole chapter on motivational strategies for engaging people in wanting to do personal work, so therapy, getting involved in some of these using some of these strategies. There's a whole chapter on motivation, so in their manual, in the Treatments That Work series. So I would refer you to that, because I think motivation in and of itself could be about a 5-hour discussion, but I just wanted to share a couple of those points to get started. Before I share my screen again and we move on to the idea of can we engage Janice, can I just ask my panelists if you've been monitoring the chat or the questions? Do we have any questions that we should talk about now before we move on?
One of them asks about the legal impact of the case and the position of the legal owner of the dwelling. As opposed to the owner of the contents of the dwelling, and then the complications that brings up.
Well, I think I would start if it's a private home versus a communal residence, like an apartment building, it would be different. But with a professional organizer or a hoarding expert like Linda, who might be the one going in, I think there's also sort of a need to know and a professional need to inform. So if there is no piece that's being brought to the attention of housing authorities or a co-op or condo board, and if things can be addressed more in a private matter, I think there needs to be a discussion as to who gets involved on the first global forefront. We might want to respect Janice's privacy and not make everything fully exposed to everybody, leading her to a higher risk of concern or misunderstanding. I think there's going to be sort of like a decision tree factor as things go along. But certainly if it's her own home and it's not affecting people around her, that's an easier piece. a communal residential setting definitely does require more of the considerations.
Also in the United States, at least, and I think to some extent in Canada, Karen may be able to talk about this a bit, is there are laws that protect people with disabilities from, while the laws in the United States do not prevent eviction of people with disabilities or people with hoarding, for instance. It does mean that they need to be provided with reasonable accommodation. And in this case, that accommodation has to do with more time to resolve a hoarding problem before being officially evicted. So that's a part of the legal, now it's a growing field, really, in terms of housing law.
Yeah, in
Is it
my
just-
limited knowledge of this area, it's similar, Randy, in Canada. The landlord and tenant representatives that I've talked to on various hoarding boards really share that the goal is not eviction, and they're very flexible to try, but they need to. There's a lot of I think support for the person not being evicted, but they need to have some indication that there's some movement towards whatever the requirement is for safety. So there's a real attempt to work with the person and any other services that are involved to prevent eviction.
Yeah. What's it like in Canada, Linda? Did you know? I mean, not Canada, it's Scotland.
In the UK, yes, same here. Yeah, absolutely. Adaptations have to be made, but the individual has to demonstrate that they are willing to receive help and change. Certainly, if there are any public health issues, environmental health issues, or fire safety issues, then absolutely they must be addressed.
Yes.
Yeah.
I would even say, although we're not talking about fire safety or fire involvement, my conversations with people who do that work here in Canada as well, is they're so very committed to giving people opportunity. They just need to see movement, right? So there is a real sense, I think that's part of the psychoeducation that I provide clients. Nobody wants anyone to get evicted or for their house to be condemned or for the fire department to come in and force changes upon them. That's actually like very much last resort. Every agency is typically wanting to really support the person, but just get safety back. And so that I think is helpful to share that perspective.
I think that's a good point, and it really is in contrast to the way it used to be. Before we learned much about hoarding disorder, there were agencies, elder service agencies, health departments who would go in and basically condemn a home and clear it out.
Yeah.
And we've learned over the years that approach doesn't work. It may change the condition of the property temporarily, but once the person moves back in, it's back to square one before long.
Yeah, it still happens, but I definitely seeing a shift and a change in people's attitudes and behaviors. So it's great.
And one of the best ways to do that is to have some sort of like a hoarding group, like a group of professionals who come together to discuss. I think that's helped us move forward because there's so many invested people who are wanting to learn more. I have one quick question before I go to our very next piece of information about Janice. So a question about, have we ever, any of us ever incorporated occupational therapy into the treatment plan? And I will say the answer is yes, but does anyone want to comment a little bit more about how they've used occupational therapy?
I've been able to get visiting nurse to, oftentimes if the doctor prescribes OT, we've been able to have an occupational therapist come in to do a lot of organizational work and helping people identify, and it might be with all the visual conflicts that we know that people have with the neurological focus and the out of sight issues with disorganization. Sometimes they've taken closet doors off of closets so that people can visually see their clothing, or doors off of the cabinets in the kitchen so they can visually see what they have before they go shopping for the items that they know that they like or feel that they need. However, and I can only speak from my perspective coming from New York, is that there's been a lot of educational pieces I've had to do, and apologies to any occupational therapists who might be out there, but I don't feel that all occupational therapists see their potential role in this kind of home clinical intervention. They tend to look at their upper, manual dexterity and activities of living. So from my role, I've done a lot of education and work with visiting nurse services to help expand the awareness and the potential of their services. Because what I do know is that any of the visiting therapists that are out there are more than willing to be involved. I just help try to enhance their understanding of how they can be of help.
Excellent. Thank you. Okay. I am going to share my screen for one last time to give you the last bit of information that we want to share about Janice. So after several conversations with Janice, she's hesitant, but a little more willing to work on her difficulties. She has agreed based on the goal of keeping her staircase clear out of respect for her children's concern that she will fall and break something again. And she was able to identify a long-term goal of having her children and grandchildren come to visit, especially now that she's less mobile and less able to go see them. She agrees to meet a therapist with experience providing cognitive behavioral therapy focused on this difficulty she has with discarding items. So now we want to just have a chance for Randy to talk a little bit about engaging someone in CBT and some of the strategies that we might want to consider.
Okay, when we start CBT for hoarding disorder, one of the things we want to do is back up and take a look at, okay, what is it that we need to address in cognitive behavior therapy? Now, the motivation part is a part of it, but the real core of what we're dealing with here are three problems. One is excessive acquisition. And we don't know from what we've learned so far about Janice whether she has an excessive acquisition problem. But we do know from the literature that more than 90% of people with hoarding disorder have an acquisition problem. So one of the things we want to do initially is to evaluate whether or not she has an excessive level of things coming into the home. So that's the first piece we need to know before we get started. And we'll talk in a minute about how we go about dealing with an acquisition problem. The second thing we need to deal with is her attachments to possessions, her difficulty discarding. When you think about it, we think of this as difficulty discarding, but when it comes down to it, what happens when she tries to throw something out? What happens is she starts thinking about the value of that possession to her, what that possession means to her, and what it would be like without that possession. So it's really the attachment to the possession that we have to focus on here, because unless that changes, then we're going to be back in the same situation if she throws things away. So just getting rid of things or just having someone come in and help her clear out is not really going to change the problem in the long run. And the third feature is disorganization. Now, by disorganization, what we find in hoarding problems is that when things come into the house, they don't get sorted out and organized in the way in which most of us organize our possessions. And there are problems with the way in which information is processed that are related to this. So that it all hinges together. If you're in the base, you listen to the basics talk, you know that some of these things are interrelated in this way. And all three of these things, acquisition, difficulty discarding, and disorganization, all are the things that lead to clutter. But in CBT, we need to address these three underlying features. They're the things that underlie the clutter. So that's what we have to deal with. So let's start talking a little bit about acquisition. Now, when we look at Janice's case, what we see is someone who over the years has collected a lot of things. And the thing that was observed early on was many of her kids' toys were still there. We'll talk more about those in a minute, but clearly there was some acquisition of those toys. How did all this stuff come into the house? Most often it comes in through buying or picking up free things. Now, how do you get control over that? Now, many times when people come in for therapy, and Janice was no exception, when she came in, she said she didn't have a buying problem. She used to, but now she avoids certain stores where she used to buy things. And this is what we see a lot with people with hoarding disorder who sometimes are able to control that acquisition to some extent. The difficulty is that in the long run, this isn't a very good way of controlling it, because in our cultures throughout the world, for the most part, the culture is dominated by the acquisition of possessions. And it's hard to avoid the cues to acquire. So that's a part of it. When we look at what happens when people acquire, so when someone with a hoarding problem is in a situation that is an acquiring environment, they get some kind of an impulse to acquire something. They may look at something and think, I would love to have that, and come up with a myriad of reasons why they need it or want it. And what happens during that time is a very narrowing of the attentional focus. So what they're focused on is the brightness of the object, the utility of the object, how the object makes them feel, and so forth. And what they're not able to access is the context of their life with respect to that possession. Not available to them is the fact that their home is already full of stuff. Not accessible to them is the fact they don't have any money to buy this. Not accessible is the fact they already probably have 3 or 4 of these somewhere in the home. So one of the tasks we have in dealing with acquisition is to bring the context of the person's life back into the process of acquiring. Now, the easiest way to do this is when we're in the office, and we typically do this very early in treatment. We talk with them about what kinds of questions they should ask themselves before they acquire something. And for the most part, people come up with the same things all of us do. Do I really need it? Do I have the money for it? Do I have space for it? Do I already have something else that might suffice? And when we answer those questions to our satisfaction, we either buy the item or we don't. And so what we ask people to do is we type up a list of these questions. We even laminate it, and we ask them to carry this list of questions with them wherever they go. And if they're thinking about acquiring something, to pull out the sheet and answer those questions for themselves. And if after answering those questions, they're satisfied that they really need the object, then there's no problem. But what this does is it brings a context of the person's life back into the decision-making process. The other thing we see in these acquiring episodes of people with hoarding disorder is an inability to tolerate the urge to acquire. And it is urge-based, it's an impulse. And that impulse is so strong, they can't tolerate it. And so the only way they can deal with that is to try to avoid the stimulus. And that kind of, as we said, that's an ineffective way of working with this in the long run. So the second thing we face is how do we go about building their tolerance for the urge to acquire? And what we try to do in this case is we try to treat it much the same way we would treat something like an anxiety problem, where we put together a hierarchy of situations that go from a low level of urge to buy something all the way to a high level of urge. And we have them work through that with the goal of trying to power their way through an urge without buying something. So we might start by what we call drive-by non-shopping, where they just drive by a store that's hard for them to resist. And it's remarkable how many people avoid parts of town because they don't want to drive by a store. And then we have them walk by the store on the sidewalk, then walk in and walk out, then walk in and look at something and walk out, all the way up to going in, looking at something, finding something they really want, admiring it, looking at it, and so forth, and putting it down and walking out. And in that way, we're building the tolerance for that urge and we found that this works reasonably well in controlling excessive acquisition. The second piece is perhaps more difficult, and that's how to increase discarding. And what we're talking about here is how to change the nature of the attachments to possessions, what to think and feel about a possession. Now, this is hard because we can't simply tell someone, look, you're thinking about this all wrong. You have to think differently. It doesn't work that way. We have to come up with a way of changing the way in which they relate to their possessions. Now, one of the things that we found is that in looking at what happens to possessions that people acquire, people in hoarding disorder, is they come into the home after this initial high, really, of acquiring the possession. They come into the home and then they go into a pile somewhere and they never get interacted with again. So there is never any processing that goes on, processing of whether this is something I really want to keep. So one of the things we try to do is to create a system for them to process each item. Now, when we do this in therapy, we have them pick up item by item and talk their way through the item, tell us what the item is, describe it to us and so forth, tell us what it means to them and so forth. And in doing so, we are teaching them to process the information about the item, and we try to get them to relate it to their goals and values in life that we've already established. Okay, if keeping this, if getting rid of this item means it's more likely my grandchildren will visit, that changes the equation for how meaningful it is to me. So that's a part of what we're doing now. When people look at this and they say, but the home is full, it will take years to do that. The idea is not to reduce clutter. The idea is to change the nature of the attachments to the objects. And once we change that, then the clutter we can deal with more quickly. But the idea behind this is to change the nature of the attachments. And when we look at Janice's case, what kinds of attachments do we see here? Well, one of the things that came up in the description was her saving of her children's toys. We see this a lot in hoarding disorder, and this is related to what, if you listen to the basics, what are opportunity or identity related saving. Now, this kind of saving behavior we think is motivated mostly by a fear of loss. And what are they losing? One of the things we frequently hear from people who save their children's toys, for instance, is that if I get rid of it, I won't be able to remember that feeling. Okay, it's a little bit like if you've ever read Marcel Proust, the French novelist, has a piece called Remembrance of Things Past. And in this piece, someone eats a cookie that reminds him of a time when he was a child at his aunt's and playing with his aunts and aunt's house and so forth. And the idea is, it's not just a memory that's there, but a whole visceral experience. It's like he was transported back in time. And one of the things that may be happening with people hoarding is that the sight of these things transport them back in time, so that now Janice experiences what she experienced when she had children at home. And for those of you who had kids that have grown and gone away, you think back to what was my daughter like at 4 years old? I would give anything to be back there and experience that. And I think that's a little bit of what Janice may be experiencing with these things. And so that's a part of the process, and that's a part of what she needs to talk her way through and see that she doesn't really lose that past sense. It's like an identity that she has, that she's now lost her past sense. The other thing we see is a loss of a future identity, where people see opportunities for things that will give them something in the future, that will make them a different person in the future, the person they want to be. And they can't let go of those opportunities because they may not get there. And again, they need to talk through that. The other piece, and
Pardon my interruption, Randy. I'm so sorry. Just wanted to give you all a 5-minute warning. Please continue. I just want to get that in there. Sorry.
All right. I was about to comment on that. I'll say one more thing and then open up for some more questions. The other thing we see in Janice's case is she has a refrigerator filled with rotting food. So how does this fit in? Well, one of the things we see with people who keep and sometimes consume rotting food is a different kind of attachment. It's a responsibility-based attachment. And here we think this is sort of guilt motivated. And so for Janice, and again, we have to explore it more carefully, but for Janice, she may feel that somehow it's a terrible waste way. And this is a pretty extreme kind of feeling. In fact, so extreme that we've given it a term of material scrupulosity, a set of rigid beliefs that include an exaggerated sense of duty or moral or ethical responsibility for the care and disposition of possessions to prevent them from being harmed or wasted. Now, in some of the research that we've done, it looks like waste, this fear of waste may be the primary attachment or the strongest attachment related to the development of hoarding symptoms. We've seen people who will, keep old cereal boxes and use them as stationery. Just all sorts of ways in which people are afraid of throwing things away. Now, is this a bad thing? Well, it's certainly something more of us should be like. I mean, we throw things in the landfill that we probably shouldn't. But when it gets in the way of the person's life, that's when it's a real problem. And let me stop there. I could go on for a long time about this.
Randy, it's a loss to all of us to have you on a panel because we could listen to you forever. I mean, you're so wonderful. There are some questions going back to excessive acquisitions, and people are asking what are the sources people should use? Somebody asked, are you referring to the non-shopping cart and the buried in treasures, or a more complete list of questions that you can make available to them?
No, I was really referring to the non-shopping card in Buried in Treasure's book. Yeah, and it's, I mean, you can come up with your own. They're the same things. If you ask anyone, what should you ask yourself before you buy something, they would come up with the same question. So it's nothing that different or that unusual.
Karen, are you seeing other questions?
Yeah, I just wanted to acknowledge we did have a comment about our previous discussion about the difficult position that landlords are in, especially when there are extreme safety issues. So just wanted to acknowledge that yes, that's an excellent point. And that person said there was a fire in the Toronto area, which I absolutely remember, that displaced a huge number of people from a high rise based on the fact that there was multiple people with hoarding difficulties on one floor. There was a fire and it ended up, affecting many, many people. So if we all take a moment to think about what a landlord would be experiencing in terms of worry about situations like that, or the massive financial implications of a situation like that, that's an excellent point. Alan asks, why do we use the drive-by non-shopping for acquiring behavior, but we don't use it for things like substance use behavior, which is also positively reinforced?
That's a good question. I think it is something. I think that's the sort of thing that could be used not only for substance abuse, but for addictive behavior, but gambling in particular.
Go ahead. Sorry, go ahead.
I'm sorry. I know we've got like 1 minute left. We did have some feedback from an occupational therapist from Minnesota who stated that they have developed more of an inclusive role of occupational therapists in working with people with excessive clutter, and that they could benefit from increased, I've got to make sure, functional activity tolerance among other practical function-based interventions. And a key piece, at least in the United States, is that visiting services can be covered by most insurances. So when we're looking at the cost of interventions, obviously anything that can be covered by an insurance in a particular area would benefit a person who has to outlay private monies. So thank you, Jennifer.
I wonder, there's a couple of last comments, but I do know it is 12:15, and I think that the IOCDF is actually amazing about keeping time to make sure that everybody gets a chance to go to their next session. So maybe I'll
Yes,
wrap up.
unfortunately, we are going to have to wrap up here.
Okay.
Thank you all so much for the attendees and this excellent panelist. You guys did such a great job. I'm sorry to all the questions we didn't get to. Hopefully you'll be able to connect with people throughout the rest of the conference today. But otherwise, always email your questions to conferences@iocdf.org and find a list of resources on the event website as well as our normal page. But thank you so much. All of this information will be available for 30 days online, including the recording of this talk. So reach out to the IOCDF if you have any other questions, but thank you and enjoy the rest of your weekend.
Thank you.
Thank
Thank
you.